be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Welcome to this special online edition of the Lung Cancer Living Room. We're coming to you tonight as we shelter in place in California and from homes around the country as we address a topic on COVID-19, what it is and what it means to the lung cancer community. As we do with all of our living rooms, the focus is on educating and empowering you, our viewers. It's indeed unprecedented times, and we all feel like our lives are spinning out of control. Tonight is to empower you and give you back a sense of control as best we can. So we're going to answer your questions to help you through these difficult times. We all have a role to play here, and we must do our part. Unfortunately, it looks like Dr. Christine Lovely will not be able to join us tonight. She's working at the hospital at Vanderbilt where they have received their first patient. So I do want to give it out to all the doctors, nurses, and those working on the front lines as they work in what are highly unusual circumstances. So what I ask all of you tonight is not to give in to fear, but to hold on to hope. Don't spread misinformation, share the facts. To that point, I would ask you to go to reliable, reputable websites, be it the CDC, the World Health Organization, your state and local health departments. I would like to offer a caveat that this is a fluid event. We are witnessing things unfold in real time, and we don't have answers to all your questions. Things are changing quickly, daily, maybe even sometimes hourly. So we're going to answer you to the best of our ability with the knowledge we have in hand at the moment. And for those questions we don't have a chance to get to tonight, and lots of questions, collecting them all and best to answer them. We will get answers from experts around the world, and we'll collate those and post them online. And without further delay, I introduce tonight's panelists. We have Dr. Natalie Thornburg, a respiratory virus immunologist working on the front lines at the Centers for Disease Control and Prevention in Atlanta, Georgia. Dr. Max Diehn, Associate Professor of Radiation Oncology at Harvard University here in California. Hopefully, Dr. Christine Lovely will be able to join us tonight. She is Associate Professor of Hematology and Oncology at Vanderbilt University Medical Center. She's an expert on ocular and lung cancer and a member of GO2 Scientific Leadership Board. And finally, myself moderating. I'm not Bonnie. I'm not the older sister or the younger sister. I just happen to be the virologist on staff at GO2 Foundation for Lung Cancer. I'm Amy Moore, and I'll be trying to moderate tonight's discussion and help contribute to the discussion as I can. We'll also have members of our science and research team and others on staff monitoring the Facebook Live feed and YouTube feed. They'll be sending me your questions as they come up. I'd like to remind everyone that the lung cancer advocacy groups Join this GoTo Foundation, Longevity Foundation, Lung Cancer Research Foundation, LCFA, and others to issue a joint statement several weeks ago on COVID-19 and what it means for the lung cancer community. And we've been releasing weekly updates on Monday for the past several weeks. They're online and you can find those and make sure you have access to them. And I'd like to give a particular thank you to colleagues, Dr. Upal Basoy with Longevity Foundation and Janet Freeman Daly, co-founder of the Ross Wonders, who are helping me kind of develop those updates on a weekly basis. Before we dive into the discussion, I'd like to give a little bit of history for how this moment and why we're here tonight. So it all began with an outbreak of a novel coronavirus in about 41 patients in Wuhan, China in December 2019. The symptoms presented as an atypical viral pneumonia, and this situation is progressing rapidly around the world. Countries are at the brink, and you've probably heard and seen stories out of Italy where cases are rapidly expanding and their healthcare system is basically on the brink. And so on March 11th, 2020, the World Health Organization declared a global pandemic, and President Trump declared a national emergency here in the United States on 13th, 2020. Now, with all that being said, I have some questions. I've tried to anticipate to the best of some of your concerns, some of your fears, and I'll work through those, and as questions arise online during the chat, we'll also try to get to those. We're going to start with what we're calling Virology 101, some basics of what this virus is. Natalie, I'd like to start with you, and for our viewers, can we just convey to them what is a virus?
It's like a bacteria, but different than a bacteria, in that it needs a host to grow. A bacteria can grow on its own. A virus needs a cell to grow in. So it's usually a protein, some nucleic acid, sometimes a lipid on the outside of the surface, and it needs to attach to a cell, be a human cell, an animal cell, a plant cell, to get inside that cell to make more of itself and then spread. And that need, the way that we handle infections are different.
So we see SARS-CoV-2 and we see COVID. So can you explain for our viewers and what we're talking about as it relates to each of those two terms?
Yeah, well, the WHO and a naming organization within the virus community decided to do a little bit like HIV and AIDS. They had to name the virus separately from the disease. So COVID-19 is the disease one gets from a SARS-2 infection. So it's a coronavirus disease, 19 being the year that it was discovered. SARS-2 was named because of its similarity to the SARS virus. It's in the same species of viruses as SARS. So the name is SARS-2 of the virus, whereas COVID-19 refers to the disease that you get with the viral infection.
Tell us a little bit about transmission. You know, people hear about aerosol, droplet. How is this virus transmitted?
Well, we don't have a whole lot of epidemiologic information yet to say for sure how the virus is transmitted. We know that most coronaviruses are primarily transmitted through droplets, large droplets, and close contact between individuals. There's viruses that can be transmitted that way, droplets being large and heavy, and they fall quickly, whereas aerosol hangs in the air. So you have viruses that are true aerosol transmitters, like measles, and if someone comes into a room with measles, it can kind of hang in there, and that person can leave the room, and 2 hours later, another person might come in, and that virus is still hanging in the air in these very, very small particles, and you can become infected. Whereas droplet transmission, virus is associated with these big, heavy, wet droplets, and you sneeze, and if you're very close to someone and they sneeze, you might get a direct infection from those, or you might sneeze onto a hand and touch it, and then touch your face and get it that way. So we believe that most coronaviruses, including SARS-2, are probably transmitted primarily through droplets. So close contact, sneezes, surface itching, as opposed to true aerosol transmission.
As you talked about a little bit ago, viruses need to infect a cell through a receptor. So can you tell us why the lungs may be particularly susceptible to infection with this virus?
Yes. So we've identified the cellular receptor to be A2. It's the same receptor that the SARS-1 virus uses for infection. So the ACE2 receptor is present in both the upper respiratory tract and the lower respiratory tract. And that can be particularly dangerous because if it were just present in your upper respiratory tract and you got an infection, it would stay there and it would replicate up there. But being both upper and lower, it can upper, replicate, and if your immune system is able to clear it, the virus can move lower because the receptor is present lower and move into your lungs.
A common question that comes up is how long can this virus survive on surfaces?
Well, it depends on the surface. So we've done some survivability studies. Well, it was with a collaborator did most of the studies at Rocky Mountain Laboratories. So they found it's able to survive in the air. There's something called a half-life. And so a half-life is the time it takes for half of the virus to disappear or half of anything to disappear. And so you can imagine a half-life of, say, like 4 hours. So 4 hours you would have half, and then 4 hours after that you would end up with her, and then 1/16 and so on and so forth. So we have found the half-life depends on the type of surface, ranging from 1 or 2 hours to like copper and stainless steel to up about 8 hours on plastic. So it lasts longer on plastic. They tested it in aerosol, so it was able to survive in an aerosol in the air for about the half-life being about an hour. So it can aerosol and it can be present in the air, but we don't have significant data yet to suggest that it's a true aerosol transmission. But in theory, it could be, but less likely droplet because it survives much longer on surfaces.
So you alluded to this a moment ago in your discussion about measles, but there is something we call the reproduction number or R0 number for viruses and infections. And can you speak a little bit to what is for COVID and why that's important?
Well, the R0 number is an estimation, it's an epidemiological estimation of how well a virus transmits or how it becomes transmitted between people. So it means how many, if you have one patient, only how many other individuals can that one patient transmit the virus. And you can imagine there's a lot of different factors involved in that number. There's a lot of different living conditions that feed into that number. There's a lot of different behavioral factors. There's even the health of the individuals around you that really affect that number. So it's an estimate, and that number is still a little unclear for this particular virus. But I think estimates right now are ranging about 2. So one person who's infected might infect 2 new people. And so that might explain one of the reasons why we're starting to see a real increase, is because with every one, you infect 2 more people, and that's an exponential growth.
And there's some debate, obviously you've seen it and heard it back and forth about, is this worse than flu, is it not worse than flu? And that ties in partly to the discussion we're having on R0. Can you speak a little bit to that point, how this compares to flu, how many people does flu normally infect, for example, and give us a frame of reference for what we're discussing here.
Well, hard to figure out. People have been talking a lot about, you've been hearing a lot about the fatality rate. Is the fatality rate. 2% in Germany, I've heard closer to 0.1 or 0.2%. But to really determine the case fatality rate, you have to have a denominator. And at this point, it is much too early to have a true understanding of the denominator in any country of how many cases there are. We know how many cases that have been detected and confirmed, but there could be a lot of people around with mild symptoms or no symptoms who have the infection, and we don't really know that number. It's hard with upper respiratory virus infections because you don't know whether you have a scratchy throat from the pollen or something very mild. And not everyone's going to go to the doctor every time you have a scratchy throat, nor should you.
Most of you hopefully are aware at this point. The main symptoms are fever, cough, shortness of breath. That's very similar to flu, and we're still in the midst of flu season. So how soon after infection do symptoms appear?
I think our best estimate between 2 days post-exposure to about 14 days post-exposure, with the median being around 4 or 5 days.
A lot of people want to know, what do I do if I start having symptoms of COVID-19?
I think it's important to emphasize, if you're concerned that you may have the virus and your symptoms are very, very mild, that it may not be prudent to go to your healthcare provider if you're not feeling well, and certainly don't go without a call ahead of time. You have to think, of course, think about yourself and what having an infection would mean, but also exposing unknowingly other persons in that healthcare facility, as well as exposing healthcare workers. We really have to protect everyone around us. So at a very minimum, you have to go ahead and say you're concerned about this so that they know you're coming in.
I think people want to know what to anticipate in terms of timeline. So how long does it take on average from developing an upper respiratory infection to it becoming a more serious lower lung infection or pneumonia? Do we settle on that yet?
Coronavirus infections, they can start mild and then they can turn worse. I think the timeline to that is approximately, the first 5 days you might have mild symptoms, and then you can take a turn for the worse around day 6 or 7, all the rough approximation.
Some people want to know, how can I discern if I have flu or if I have COVID? Is there anything that we can really distinguish at this point? How do you make that decision? Do I need to go more urgently and be tested, or can I get tested? Is it developing labored breathing be the key deciding point?
Well, I think by symptoms alone, it's not tell whether it's novel coronavirus or influenza or respiratory illness or other cause that causes similar symptoms. That's, of course, one of the difficulties and why testing is so important.
I would also add on that point, in addition to calling your doctor, many local health department sources for what to do should you fear you've been in. So, learn where those resources are for you in your community and avail yourselves of them as we go through this period of uncertainty. Again, I want to speak, broadly to the numbers as we understand them today. And so I listened to a webinar last week, and, just kind of for ease explanation, they talked about if you had a, population of 100 patients, 80 of those are going to have relatively mild, uncomplicated infections. 9 of those will require hospitalization. 9 will have more severe deaths requiring ICU support, and there will be 2 deaths. What do we know about the fatality status? You alluded to the fact that because we don't know the denominator, we don't know how many kind of asymptomatic cases there are out there currently, that number may change. So can we speak to a little bit to where we are today in terms of mortality?
Seems like the numbers are quite different country, and we don't really have a good understanding of that. South Korea, the numbers were low for fatality rate. They were, I think, around 1% or have been around 1%, whereas the numbers in are much higher. I think they're more like 4.55%, and then in Germany, much less than 1%. We just really don't have a good understanding now of why we're seeing such drastic differences between countries. And it's going to take more research and more understanding about why that's true.
If we don't test enough, you don't know what the denominator is. It also includes the age of the patients that are getting it. And so, for example, in South, the early data at least suggested that in that country, there was a large fraction of younger adults who were testing positive, and that may versus in Italy, where there was a bias towards more older individuals getting it that had comorbidities. And so those kind of things could lead to, of course, very different numbers in different countries, even though it is the same virus all over the world.
And now we're going to dive into prevention. So again, we've all heard about washing our hands, soap and water, 20 seconds, hand sanitizer, if you're lucky enough to find it in the store. Beyond that, using good respiratory hygiene, covering your coughs and your sneezes. I think I mentioned this to you, but a lot of people want to know, why does soap work, and why in particular does antibacterial soap work if it's a virus? So can we explain just in simple terms how soap kind of combats the virus?
Soap makes something called micelles, so little tiny bubbles that physically hold things and wash them away. So they can take dirt and viruses and bacteria and wrap them in a bubble, and just it's a physicality of moving the dirt and the viruses away. Antibacterial soap works on viruses because it just works the same as soap. So using antibacterial soap versus regular soap, it doesn't really matter.
Many of our patients must travel for their treatment, so some of them wonder, what do I do if I need to travel and I don't have hand sanitizer, or maybe not have access on the road, or don't want to use, public restrooms? So how do you advise patients to best protect themselves if they find themselves in that situation, or they're going to pick up their, college-age kids who were just dismissed and, need to be picked up? How can you protect yourself out on the road? Is there anything beyond take your own soap and wash your hands?
Those are obvious and very good things to do. So bring hand sanitizer if you can get it. Of course, the best way to protect yourself, if you can avoid the travel, would be to avoid the travel and to practice social distancing at home. It can't always be avoided. You could avoid it, then one would try to do the best to, ideally 6 feet from other individuals. And so, I think number one, try to avoid traveling if you can. If you cannot, then bring hand sanitizer, bring soap, try to stay apart from others, and do the best you can.
Yeah. So that brings us to the next topic of social distancing, which we're all now doing religiously, keeping ourselves far apart, 6 feet at least, from the next individual outside our own family. So this is part of our effort to flatten the curve. And there was a great graphic in this week's update to the Lung Cancer Advocacy Group's statement, if you haven't seen it. There are growing measures at the national, state, and local levels. Here in the Bay, as I said, when we started, we were sheltering in place. This gets back to our earlier discussion around the R-naught. And in the webinar that I participated in last week, Natalie, you were saying that currently it looks like we may have R0 reproduction number of around 2.5 for this virus. The goal is to get it down to 1.0. Can you explain why that's kind of a useful number and how social distancing can help flatten the curve?
You can imagine if you have a lot of people in a small space and you sneeze, those respiratory droplets can infect people who are right here close to you. So if you have 4 people crammed around you at a parade and you sneeze, you may have infected 4 people. So you're in your small space, your R-naught is not 2, 4, because you just infected 4 people. Whereas if you are physically spread apart and you sneeze, may have had some in the airspace, but it didn't move 6 feet. It doesn't have wings. And so if someone is 6 feet away from you, unless they come and touch something that you sneezed on, you may not be able to get it. So just being physically separated from someone makes it less likely that you're going to transmit the virus and can decrease that R0 number. So our behavior affects how many people we can infect.
And that's necessary, again, to hopefully break the chain, right, of transmission and infection.
Because you can imagine, if one person infects one person, okay, you had 2, but if one person infects 4, and then each one of those 4 infects 4, you get an exponential increase of cases, and then it just overwhelms the medical system. So if we slow that down, then we just don't have many cases. Doctors can handle those serious cases, the serious infections, medical attention.
So now many of our listeners have a morbidity. They have lung cancer. We know that for seniors age 60 and over, or those with high blood pressure or cardiovascular disease, diabetes, they're all at increased risk. So we know that these patients are being advised to stay home. Some questions have come in about masks. You know, should we be wearing N95s? Is N95 better than a surgical mask? And again, we've heard the statements be made that we should not wear any masks, that we should kind of hold them in reserve for the medical providers. We're running short. Max, what would you say? Should they be wearing masks as they go in for treatment? And do they need an N95? Will a surgical mask afford any protection in this situation?
Yeah, so that's a complicated question, of course, for a variety of reasons, including the issue you mentioned that it's very important that the masks are used in the most appropriate fashion, since we may need a lot of them and there may be a shortage. So if people use them in where they're not useful, then that ultimately will harm society. So, you know, in general, our policy at Stanford is that for individuals who don't have symptoms, they shouldn't wear masks. But if you, let's say, have, let's say, allergies, so you have some runny nose or mild even from that, and it's clear you don't have tested COVID-19, so you have testing. Even in that case, that we would ask people to wear masks. Part that is, of course, because of the sensitivity around anybody with symptoms currently. But the average patient we see should not be wearing a mask, and including particularly the N95 mask.
I have questions from caregivers who are staying with family and friends who may have cancer or other comorbidities. How should they navigate that scenario? You know, there's a lot of concern. Obviously, we don't want people most at risk going out right now, but, you know, we've said try to get someone to go out and get your basic supplies or, you know, pick up your prescriptions. There's a lot of anxiety about caregivers introducing something to those most vulnerable. How do you advise addressing and navigating that situation?
I think that's a very important question, very timely question. Even a patient who's at high risk, let's say due to age or having active cancer, self-isolates at home, if there are people in the home that are frequently going in and out and are coming in contact with potentially infected people, that could ultimately lead to the at-risk individual being infected. And so the best advice is for all the household members that interact with such an at-risk individual to also practice all the things that we're discussing, particularly the social distancing, where one tries to stay 6 feet away from others when one is out. Important trips outside the home. You know, right now is a good time to stay home and more time with family, and to really minimize unnecessary trips outside the home. It's unrealistic to say no trips outside the home. Of course, people only to get food and medicine and occasionally for other things. But it's remarkable how quickly one can limit the number of trips. I just noticed it in my own family's life, given that what I'm doing for the past week and a half, 2 weeks, when really you can really minimize how often you go out if you think about really just going out for the most necessary trips. And then those caregivers, of course, when they return to the home, when they return to the home, should then wash their hands or use hand sanitizer to really try to practice really excellent hygiene.
I'm getting a lot of noise in my ears. I'm not sure if everybody can hear that. All right. Sorry about that. So another question is, should the general lung cancer population shelter in place even if that order has been passed where they live because of their vulnerability? Should they be proactive on that issue?
I think for at-risk individuals, it is currently a good idea to shelter in place, even in locales where that order has not been passed. We know this virus is basically in every state, and we know that we are underestimating, or we don't have a good handle on the total number of cases in the U.S. And so if one is in the higher risk groups, the best thing you can do is to protect yourself by isolating at home.
We've also been asked, obviously we encourage every flu shot because that's your best defense against getting the flu, which can mimic the symptoms of COVID-19. But the question came on about, do you advise patients who are old enough and it's appropriate to get the pneumonia vaccine?
I think that's a good discussion with their oncologist or primary care doctor. Either any of the vaccinations, the flu or the pneumonia vaccine, even though, of course, we're having the COVID pandemic now, influenza or the common flu is still around also, and so there is still utility in having the flu shot. Now, a question becomes, if you don't have to go see the doctor for something else, do you necessarily want to go in and see the doctor just for that? As we already discussed before,
right.
It makes sense currently to try trips. It's in the setting of our doctor, I think that's a very reasonable question to ask.
So now, on this a little bit earlier, the role of asymptomatic transmission. I know hopefully sentinel surveillance will begin or has already been, so we can get a handle on how many people kind of are out there who are actually carrying it without symptoms. Do we have anything to add on that? I think it just reinforces the importance of that there may and are likely asymptomatic carriers.
Yeah, there isn't a lot of good published or publicly available data yet to firmly say that there is asymptomatic infection or asymptomatic spread of this. I think we're beginning to see a little bit of preliminary data that at the very least pre-symptomatic infections. So people who don't know they're infected, maybe we determine in a contact investigation, someone will come up and test positive and then get symptoms a couple of days later. Now, whether they're transmissible in that period, we don't know yet. Beginning to be a little data indicating that's possible. And, we can't, it's just not possible to test every person under every circumstance, especially thematically. So we're going to have to rely on our behavior at this point, rather than just assume that a test is going to be able to every single case. We're going to have to make sure we're using good behaviors to protect ourselves and to protect the community around ourselves.
People, are still at risk about how long the virus can live on different surfaces. And so what does that mean for their daily routines? For example, when it comes to produce and things that they purchase at the grocery store, or deliveries and packages that, arrive at their house, laundry, clothes. how should they be approaching kind of these day-to-day routines in the new COVID reality?
I mean, I think we should be aware of high-touch surfaces. You're going to be going out, know where people touch, know where people cough on, and be aware when you use that pin pad at the grocery store that hundreds of people have touched that pin pad, and there could be virus on there. If it's able to that surface for 8 hours or 12 hours, there could be virus there. So just think your hands have virus on them. Don't touch your face before you leave the store. Use hand sanitizer. The second you get home, wash your hands. It's just a good habit. Every time you walk in your door from outside, wash your hands. I don't particularly worry about clothing as much because it's not high touch. I consider people wiping their nose, sneezing on their hands, touching things that they might get a lot of virus on. If it's being shed from the nose and the mouth, where are those secretions ending up? What are they touching or sneezing on?
Mm-hmm. As a matter of practice and how we're kind of adapting these practices in my own home, for my kids, my husband, when we go out, we walk for exercise, we come in, we have a designated bathroom where we wash our hands for 20 seconds. Before you go anywhere else in the house, we try to minimize the spread of any potential germs and keep it as close to the entrance of the house as possible. I made a little sign for my kids, stop, wash, go, to try to reinforce those behaviors and patterns. And we all get used to it. When I was getting ready to cross the street today to go pick up some of my daughter's remaining school materials that she needed for learning at home, the crosswalk button with my elbow, we've got to train ourselves to use these behaviors, and you've got to learn to think. And, it's hard for me too. I talk with my hands. I like to touch things. I like to touch people, very, very much a people person, but we have to reel ourselves in order to break the cycle of transmission.
At the same time, I don't want people to be afraid of everything that's coming into their homes. If we're talking about the virus living on a certain hours, you bought a roll of toilet, you bought a package of toilet paper, and it was in a factory, and it came to the store, and it sat in the store, and then it's been in your house for a week. There's no virus left on that from the outside. So every surface in the world is not a danger to us, and every package coming in is not a danger to us. We're thinking in the context of hours and not days or weeks.
Testing, how does it work? What are they testing?
So the gold standard for testing respiratory virus is an assay called PCR, polymerase chain reaction, and it detects the nucleic acid in the virus. So your physician will take a specimen, a swab of your nose, a swab of your mouth, and then the virus will be on that swab. And then this assay will detect the genetic code that's specific to that virus and different from all other viruses. So we'll be able to tell, do you have this coronavirus? Do you have a different coronavirus? Or do you have like a flu virus?
When you go in and get tested, what are they collecting? Nasal swab, throat swab? What to expect if they have to be tested?
I mean, I think at the very beginning of testing, before we really understood what specimens needed to be collected, there were a lot of different specimens being collected. And then that recommendation changed to a nasopharyngeal swab, so a swab in the back of your nose, and an oropharyngeal swab. And I believe that may be changing again to nasopharyngeal swab. If it hasn't changed already, it may soon be just a nasopharyngeal swab. But it'll be either some combination of nose or throat.
To doing the nasopharynx swab alone, in part because of also preserving the number of swabs, since that's also an important part of the testing is collecting the sample and all those items available.
And I know Stanford recently developed its own test as well, correct? So,
yes, correct.
Multiple groups are, companies developing tests to add to CDC's capabilities. So where, in light of that kind of a national level as far as availability?
Yeah, I think initially public health labs had testing capabilities for a couple weeks now, and that my understanding is there's a lot of hospitals and academic medical centers coming online now, as well as some private testing companies, so that there should be more and more tests available.
In the last couple of weeks, institutions have come online with their own tests to add to the capacity of the previous CDC test, which of course still exists. We're just adding more tests. The Stanford lab currently running 100 to 200 a day, but with scaling up the test to, in the next week or so, be able to run 1,000 a day. And we're currently testing both samples collected at Stanford here in the Bay Area, as well as other local hospitals, and really seeing a dramatic uptick in the amount of testing that's being done, which is great news.
So Max, a study done in China looked at CT scans and compared those results to RT-PCR, kind of what Natalie was describing as the gold standard. So can you talk a little bit about that study, what they saw on those CT scans, and are CT scans on a wide scale practical in the U.S. or warranted? What does the data suggest at this point?
Yes, so the study you mentioned was an interesting paper out of Wuhan, where they looked at about 1,000 patients that were seen at the large hospital there from early January to early February, who were all suspected of having the COVID-19. And of those that were suspected, by suspected it means that they had some symptoms, like the 4 symptoms we talked about, that suggested they might have it. Of those, 88% had findings on the CT scan. So the CT scan looked abnormal, consistent with the pattern that we see with COVID, while as only about 60% of those patients had a positive PCR test. So on its surface, one might think that means that the CT scan is a better test, but that's really the case and hasn't really been proven. The issue is that the changes that we see CT scans with COVID-19 can also be seen with a variety of other viral pneumonias or even other inflammatory conditions that affect the lung. So there's changes that we see which are called ground glass opacities. Many of our lung cancer patients watching will be familiar with that term. This looks like ground glass, or sort of white and grayish flecks within the lung, which is supposed to look black on CT scan. But they are not specific for COVID-19 is the issue. So while it's true that you see them in a patient who's having a COVID-19 pneumonia, you can also see these in other conditions. And that is the issue, that if you do just a CT scan in someone who has symptoms consistent with pneumonia, that doesn't necessarily mean they have COVID-19. If you do the PCR test that Natalie described, that is a very specific test that is testing for the genetic material of the virus, and so we know if that's positive, the patient has the virus. And so because of that, CT scans aren't currently being recommended as the way to screen for COVID-19. It's the PCR test, and there's additional issues, of course, with active CT scanners, and also issues where if you have someone who you think might have COVID-19 but you're not sure, and you put them in a CT scanner, then you have to clean that CT scanner very well before you put the next patient in. There's many additional complications that mean that the right test is the PCR test.
I want to switch now to treatment. Obviously, at this point, we're talking supportive care, intubation, non-invasive ventilation, ECMO. Natalie, what can you say on the topic of vaccines and where current are? And also want to, some people may hear about, are we talking about preventive vaccine? Are we talking about prophylactic vaccine? So preventive would mean to keep you from getting infected in the first place. Prophylactic would mean you've already been infected and we're going to try to give you something to help at that. Where are vaccine efforts? And can you speak a little bit to the timeline of what is normally required?
So there is an accelerated pace for vaccine development, which is really great. The research, the public health, medical community are really working together amazingly and pushing very hard to develop a vaccine. It would normally take years for a vaccine to get to market. But today, actually, or was it yesterday, I believe the first participant in a phase 1 clinical trial for the first vaccine was vaccinated in Seattle, which is just remarkable since we just discovered the sequence of this virus just a little more than 2 months ago. So that's based on the surface protein, the spike protein, and it's sponsored by, partially sponsored by the National Institutes of Health, and it's been led by the company. And it's not actually protein. It's a protein that it's a nucleic acid that expresses a viral protein to elicit antibodies against the virus for future infection. So it's not for exposed individuals. Now that's just phase 1, so that's safety trials, and even at an extremely accelerated pace, I think it would be a year and a half before anything could come to market. And I think even that's a pretty ambitious timeline, and it's probably more than a year and a half out.
In conjunction with the development of vaccines, we're also pushing the development of antiviral medications. The analogy for this would be the Tamiflu that you might get a prescription for if you get infected with flu. So where are we in terms of developing antivirals for COVID-19 infection?
I'm not an infectious disease doctor, but there are already trials ongoing with drugs like remdesivir from a local company here called Gilead, which is initially developed for Ebola, but appears to have some activity against the novel coronavirus. And so I believe there's at least trials going on in China, and also now starting, if they haven't already started, in the U.S. And of course, as opposed to the vaccine, these are studies, the therapeutic studies, try to treat patients who have the virus, whereas the vaccine is to prevent getting the virus. These drug trials are to actually to try to develop a treatment. But of course, we have to prove that it works in patients. So it's going to be critical to get these trials done as quickly as possible.
But I also want to convey that remdesivir has been offered under compassionate use and now as part of clinical trials. So given that it showed good activity against Ebola, I think the pace is moving a little bit more quickly on that front, which is encouraging. We're also using other drugs kind of experimentally, including antiretroviral medications. So that would be drugs to treat viruses like HIV, some antimicrobials, corticosteroids, and others. So there are a couple of questions that have emerged around treatments, drugs, and some risk factors. So there's been a lot of kind of news back and forth and debate back and forth in recent days on immunosuppressants, particularly if drugs like ibuprofen, the NSAIDs, might be harmful. Can either of you confirm that, or I think there's still a lot between Italian and French doctors as to that's true. Can you speak to this point? People want to know.
You were talking about this beforehand, and I haven't really been able to understand the data that they're basing those statements off of. So I don't think we've necessarily seen data to set it here, but that doesn't mean that it's not true. So I think it's just we don't have enough data to make any recommendations.
On the point of immunosuppressants, can you speak a little bit to those who might be taking immunosuppressive drugs and how that might impact for cancer patients in particular? Do we have any firm data?
And again, the firm data is lacking, unfortunately, because this is such a new virus and a new disease. The concern with patients taking immunosuppressants, whether they be for cancer or other problems, is that that could, in theory, make someone more sensitive to getting the virus, to actually developing the disease, and then not being able to control it if they were to get it. So that is, I think, a legitimate concern. Have great data to say exactly which drugs are the worst or are problematic or not problematic. Unfortunately, we don't. I think we would like a lot more over the next 1 to 2 months as the wave of patient in the U.S. picks up and all get a little experience with these patients.
Mm-hmm. So for those navigating other cancer treatment, a lot of anxiety about potential delays to treatment, triaging patients, those who are deemed more critical, less critical, concerns about the medical supply chain. Will they have access to life-saving drugs? Can you speak to these points, Max, based on what you've seen at Stanford, what we've heard so far? It's a lot of people see the stories coming out of Italy, and we're talking about triaging the worst and those who aren't likely to survive. So how are we seeing this unfold here in the U.S.?
I can only speak to Stanford, and we have not seen those terrible things that you mentioned have been happening in other countries like Italy. Now, but it's important to note that we are behind countries like Italy or China, in a case of probably a couple of weeks behind where they were. So we are now where they were about 2 weeks ago or 12 days ago, based on the number of deaths in the country. And the big concern is that if we don't do something, that we could end up where Italy is. And the thing that we can do to help prevent that is the social distancing. And so if we practice the social distancing and we really flatten the curve, meaning we minimize the number of patients who are really very sick at the same time, then we have to avoid those problems. And I'm hopeful that if we can really do this, that we will achieve that. But it requires all of us working together to do this. It's important.
Before we get some more lung-specific questions, I want to briefly touch on the topic of immunity. I've heard questions people online and Facebook and wherever, and they say, well, they're coronaviruses, so is it possible that I might be immune to this one? So Natalie, can you speak, being a virus immunologist?
There are several common coronaviruses that circulate every year, and then there's some more coronaviruses which are more rare. The viral proteins on the surface of coronaviruses are the targets of your immune system, your antibodies that bind it and then prevent it from entering cells. Now, the viral proteins on the surface of those other coronaviruses are quite different than this one. So the antibodies that might bind the common coronaviruses probably don't bind this new coronavirus, SARS-2. When we've tested it in the laboratory, serum from the coronaviruses indeed do not bind the new virus. Now, we do have serum that comes from patients who had the first SARS, and they do bind this new SARS. So there would be some cross-protection potentially between SARS-1 and SARS-2. But very few individuals who had that infection, and even fewer who had that infection who live in the United States. So unless you had the first SARS, you probably do not have pre-existing immunity against this new virus.
I think the short answer here is likely no, right? I mean, we need to be prepared for the fact that you don't have immunity against the virus. Do you anticipate that patients would be protected long term if they recover from infection? Will they have protective antibodies if they get infected and recover?
Potentially. We don't have any patients who have recovered long term. Our most recent patients are 2 months out from their infections. So we don't know, but actually and hopefully, yes.
Why are kids less impacted if nobody is immune to the virus?
I don't think we know yet whether they're not infected or whether their infections are much more mild. Really, most of the childhood infections we've found are through household transmission studies. So we have a known case, we test live in the same house of them, and incidentally unlikely we find a child who may have become infected. So I suspect that they are infected, but that their symptoms are much more mild.
And I think there was some data out of China to suggest that indeed they were infected, and that is why schools are being closed, because the risk of them being carriers and taking it to other people who are more vulnerable. So I think that's why we are where we are with school closures. Okay, so I'm going to dive in now to some very specific lung questions as it relates to COVID. The virus due to lungs. There was a paper in JTO that looked at, we had a couple of patients in China who went in for lobectomies who unknowingly were positive for COVID infection at the time of surgery, but didn't have an apparent pneumonia. What could we tell in the lungs of those patients?
Yeah, that was a very interesting study that the one you mentioned, where there were two patients who had lobectomies for early stage lung cancer and did not have symptoms of COVID-19, but then later on developed symptoms and were found to be positive. So the pathologists in China who wrote this study went back and looked at the specimens of those two patients and found that in the lobectomy specimen, there's the lung tumor that was expected to be there. So some microscopic changes that included some fluid in the alveoli, which are the little pouches at the lung units that is where oxygen crosses into the bloodstream. Some fluid in there and some inflammatory cells. So what are basically early signs of inflammation of the virus being there, even though the patients were asymptomatic.
For patients missing part or all of a lung, are they at increased risk of infection?
I don't think we know if they are at increased risk for getting the infection. I don't know of any data, and my guess would be that probably most patients would not. However, patients who have lung surgery, which can of course be a very small surgery or a very large surgery and everything in between, or who have had a lung, which can also be a small part of the lung or a large part of the lung that's affected, those patients could have lower pulmonary reserve, meaning lower amount of their lung that is still working normally. And there is potential concern that if they were to get the virus and if they were to be one of the unfortunate individuals that gets the severe version that requires hospital or intensive care unit admission, that they would have less of capacity to withstand the effect of the virus on the remaining lungs. So that's, in my mind, the main concern, and really, again, to the importance of social distancing, hygiene, the behavioral changes that we can all do to try to minimize getting the virus in the first place.
Some early data coming out of China has suggested those who recover have significant impairment in lung function, perhaps 20 to 30% reduction. To your point, Natalie, before, we're not really at long term yet, being just a couple of months out from when all of this first started. Do you anticipate lasting impacts to lung function following COVID infection?
I mean, I don't know of any data. I know the study you mentioned, I didn't actually ever find the real study. I saw a news report about it, and it sounded like a very small cohort, like a dozen patients were had after being discharged from the hospital still had some breathing issues. But it was unclear how long they were past discharge and all these things. I think it's just too early. I think the good news is that the majority of people who get the virus have a mild version, and that mild version I would not expect to cause long-lasting lung problems.
Lots of questions about different treatments for lung cancer, including immunotherapy, the use of tyrosine kinase inhibitors. So for those on immunotherapy, do you think that they would have a better response because they have a heightened immune system, or would it be the converse?
I think this is a very important question, the one that we need to get the answer to as soon as possible. We just don't have. The concern is that the immunotherapy drugs release brakes on a patient's immune system to try to make the immune system attack the cancer. Unfortunately, releasing the brake could also mean that the patient has a more brisk immune response if they were to be infected with the virus, which could then lead to more symptomatic, more symptoms, more shortness of breath, more lung damage, etc. That's the big concern. We don't really know, but and here at Stanford, we, as I mentioned, we are just in the very early days of the local epidemic, and so haven't had this situation come up in patients. And so, but this is something there's been a lot of discussion among oncologists here, and I've been on some email chains with oncologists from all over the world discussing this issue. And the short answer is we don't know, but there is some concern that the immunotherapy drugs could make the symptoms more severe. So that's different than the tyrosine kinase inhibitors you mentioned. They there's a little bit less concern there. In general, most patients tolerate those well, particularly some of the newer drugs, like for example osimertinib. And so if a patient be, let's say, virus positive but be asymptomatic or very minimally symptomatic, one could envision probably keeping the patient on. However, if those drugs can sometimes cause a lung inflammation themselves as a side effect. The tyrosine kinase inhibitors can cause what's called mucous lung inflammation. And in that setting, then of course one then also has the virus with potential those ground glass lesions on the CT scan that I mentioned. One might consider taking them off. The short answer is that these decisions, be they immunotherapy, tyrosine kinase inhibitor, chemotherapy, or whatever therapy, have to be made in a patient individualized setting. The risks and benefits of the treatment for the cancer have to be considered versus that of the virus. And so, for example, if a patient has a very advanced small cell lung cancer, which of course it grows very rapidly, then that patient really needs treatment for their small cell lung cancer. That's the most dangerous thing that's probably facing them at that moment. So if they have a positive virus but no real sign of significant lung involved virus, probably would treat that patient. Whereas if a patient has an early stage cancer and is getting adjuvant treatment, let's say, and has already had cycles, and the question is, should one give the fourth or not, then maybe one might not give the cycle because maybe the benefits don't outweigh the risk. So there isn't, unfortunately, one answer that we can give to say this is what you should do with your treatment. It has to be the balancing of the risks and benefits. Why are you getting the treatment? Where are you in your treatment course? And how severe is the viral infection? I should say that currently we are not generally recommending stopping treatment just because the epidemic is here, or the pandemic is here. Patients who need active treatment should not just stop treatment. They should generally continue treatment because, of course, they're getting the treatment for lung cancer, which is a serious problem that needs active therapy.
To your point, I think the most important consideration here is to engage in dialogue with your treatment team to make those decisions on a case-by-case basis. Related to this, the question has come up again on the issue of steroids. Do steroids increase or decrease symptom risk?
Yeah, I mean, I think during the first SARS outbreak, it was use of steroids correlated with an disease severity. So I don't think patients have been using steroids so much because they're concerned about increasing severity. So it's just not being used right now.
Yeah, I think, again, it's something that needs to be discussed with your treatment team. And the data, unfortunately, this has unfolded literally, we're 3 months in, barely 3 months into this new situation. There are so many unknowns, and obviously a lot of people are looking into these questions very, a lot of attention. So we'll be sharing updates as we get them for how this impacts your treatment. And as more data becomes available, we will be sharing that. Lastly, I want to touch on preparedness. I know we're coming up to the last maybe 15 minutes of our time together. So I think we've all been advised and would advise you all to stock up on essential supplies, be prepared for, at least 2 weeks, longer in all likelihood, a month's supply if you can. Where you can, stock on critical medications, limiting exposure. So again, using all those practices already discussed, social distancing, washing hands, all the things that we've been hearing repeatedly in the most recent days and weeks. I think it has been challenging, and people, are going out and kind of panic buying. So milk is running low, or eggs are running low. And so we want to assure people, the supply chain will hold as long as we all practice being good neighbors to one another and not being. So, golden rule applies now more than ever, do unto others as you would have them do unto you. So be a helper, like you said, we have next door, our neighborhood, we got a text from somebody who said, hey, I'm at Trader Joe's right now. Does anybody need anything? So to the extent that if you're young, healthy, able, you can lend a hand to someone who needs it, do so, to help your neighbor. And that's how we'll all get through this collectively. We're all stressed, we're all frazzled, we're working from home, we got our kid home, there's a lot of things. We're navigating serious illness, and, it's a stressful time. So let's talk about coping and wellness strategies in the few remaining minutes. I want to remind everyone of GoTo's resources, including our helpline. It's 1-800-298-2436. We stand by ready to help and answer your questions anytime. Importance of sleep, diet, exercise. If you watched our January living room, our colleague Susan Smedley did a great session on, breathing exercises. And so really take care of yourself. And just because we're at home doesn't mean we're not connected. We're all together here. Maintain those online connections. Pick up the phone, talk to people, don't just rely on text. Resurrect hobbies. I used to draw when I was a kid, I got busy. So, hey, I started drawing and painting again. It helps me relax a little bit. But I know people are fearful. There's a lot of anxiety about the unknowns. And so can you both kind of weigh in on what we can expect in the coming days and weeks? I know none of us have a crystal ball, but how bad will this get? People want to know. How long will this new reality last realistically?
Well, right now is the time to act, and right now is the time we can really affect how bad this is going to be, to determine whether we're going to be South Korea, become Italy. Are we going to continue to have exponential expansion of cases, or are we going to level off into a more linear increase in cases? So, we will have more cases, start having more community spread. All of us will start to know people who've become infected. But as I said earlier, our actions can really and will really affect our situation here. And so I think we should take it day by day and know what we can control and control those things, and talk to our friends and families and try to emphasize the seriousness of the situation, but without panicking, and knowing we do have control of some things. We can do ourselves pretty well if we're able to stay at home as much as we can.
Max, do you have any thoughts on this?
Natalie said that extremely well. I think no one knows exactly how it will get, but the important thing is, and the empowering thing is, that right now we have a chance to determine how bad it gets. And if we do the right things, then this will be much less of a problem if we don't do the right things. And that's both, again, from protecting individually patients who are at risk, like our lung cancer community, but also protecting people outside of our lung cancer community who are at risk. As far as how long, we just don't know. It's not going to be days. We know that. It'll be weeks to months. But there's some positive news. Like China have, they were, of course, the first. but they have definitely turned the curve, and it didn't take them 6 or 12 months to do that. So they did that by instituting the social distancing measures that we are now trying to also institute. Really a roadmap. We're not doing an experiment where we don't know the answer. We know the answer. We know the right thing to do, and if we do it, then this will be a much better outcome for all of us. So I think we just work together, then we can beat this thing.
The pace at which we're understanding this virus is truly breathtaking. To go from having identified a novel unknown virus in December to, as you said, Natalie, giving the first vaccine to a patient yesterday in the span of a little more than 2 months is unheard of, really. It speaks to the power of what this community can do and will do. So today is a very important day. I have on screen here it's St. Patrick's Day, but that's a very meaningful day for the person who really, created the reason why we're here tonight. Bonnie Adario is today a 16-year survivor of stage 3B lung cancer. So hi, Bonnie. Hi. I know everybody sends their love and hugs, and you're such an inspiration to everyone here. And so again, hope is real. Bonnie's here. She's not planning on going anywhere. She's at home, and she knows that all of you are watching tonight. Again, from our team to all of you, thank you for being with us, and good night.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.